venue en même c'est un samedi matin. This panel is actually in English, but I wanted to underscore the international aspect of our panel. So to start, I'm going to have each panelist introduce him or herself in native language.
Guten Morgen, mein Name ist Patricia Xuonggg, ich bin Dramaturgin aus München in Deutschland. Buenos días, soy la doctora Julieta Espada de Buenos Aires, Argentina. Allá tengo a mi hinchada, así que gracias por levantarse temprano. Hoy, después de la noche de anoche, les puedo asegurar que vamos a tener una sesión espectacular. Guten Morgen, ich bin Tanja Fischer, ich bin auch Dermatologin aus Berlin und ich freue mich, dass ihr alle schon so früh hier seid und wir heute über den Sonnenschein und deshalb umso schöner. Vielen Dank.
Good morning, I'm Lisa Gunnabaum. I'm a facial plastic surgeon at the Mayo Clinic in Arizona. Good morning, I'm Brittany Howard. I'm a facial plastic surgeon. I practice with Dr. Gunnabaum at the Mayo Clinic in Arizona.
Доброе утро. Меня зовут Александр Ривкин. Я врач-косметолог в Лос-Анджелесе. В общем, да, здесь.
Steve Diane, facial plastic surgery from Chicago.
A really fast introduction for myself that this is a cool haptic robot, which I am not. So I don't actually believe that you can get away with never having an error. Human error cannot be eliminated, just reduced. So this is really quickly an email that I received recently that we had left a sharp in our little box after a minor procedure, and the people who do the cleaning were super upset. I'm also a big believer in Swiss cheese theory by James Franklin. Sorry, that it's never one thing that creates a problem. It's always a series of bad things that are a perfect storm. So I've asked our panelists to focus on that. What were the variety of things that went wrong that caused your meltdown? I'm also a believer in checklists, things that we really need to keep track. Because when you do the same thing over and over, like pilots, then you will be able to reduce your complication rate if you have a checklist. Now these are hard to put into place. It's a long time to put them together. I actually am very resistant to creating checklists because I think it takes a long time, but they do work. This is the WHO surgical safety checklist, which has also been proven to reduce. So what do I think went wrong with this? We had actually introduced a checklist for sharps in our minor procedures, but it was just manual, the nurse that works there. We had not included the blade because originally the reason we created the checklist was to watch the needle. Like we have to be much more careful because no one's keeping track of this like they do in the OR, but we didn't think about the blade. So a series of things went wrong. We lost the needle. We're like, oh, we need a checklist. We need to look at the checklist together. And then we forgot that there was a sharp also on the tray. That actually. So I'm going to turn it over to everybody else who can speak. The first speaker is Dr. Diane.
Thank you, Lisa. Pleasure to be on this panel. I've been doing all these panels for many years. Lisa asked us to present one of our stories, so I thought I would tell a story. And it happened 8 years ago. I get a call from the emergency room in New York. I live in Chicago. And it's a husband of a woman who just got treated by her plastic surgeon with filler in the face. And she was having a problem. So he took her to the emergency room. He says her face is swelling, it's red, it's irritated. It looks like something he saw in an article I published that he Googled and found. I said, why are you calling me? I'm in Chicago. How'd you get my phone number? He's like, I just figured out I found your phone number, which kind of scares me in itself that he was able to find my phone number. And I was like, well, what is the emergency room doctor doing? Well, the emergency room doctor says there's nothing to worry about, and we're sending her home. I'm like, well, did you call the plastic surgeon? Yes, the plastic surgeon says everything's okay, just send her home. I'm like, have you seen anyone from the plastic surgery clinic? No. And he says to me, her face has got this purple color. He's describing it to me. It sounds exactly like libido reticularis. Sounds exactly like she's having a vascular ischemic event. So I said, I can't give you any advice. We don't have a doctor-patient relationship. I've never met her. I don't know her. I don't have a chart. I don't have a license in New York. And I can't override the doctor that's taking care of her right now. And so then I was stuck with this ethical dilemma. Because I know the solution was probably to recommend hyaluronidase, but if I start giving her an answer about what to do through her husband, then I'm medically liable. So it's a very interesting ethical dilemma case. So what I ended up doing was I ended up saying to her, call your plastic surgeon. The plastic surgeon said, I don't care, I want nothing to do with this. I said, tell the ER doctor, give the emergency room doctor my paper, have him read it, and if he has any questions, he can call me, I'll talk to him and consult with him, and then he can treat you, which is ultimately what happened. So it was a very interesting situation. She got better, and she had a vascular injury to her nasolabial folds, and this is pretty common when you see something like this, and hyaluronidase has been very effective in treating this. But this is something that I saw multiple times early on. I started doing fillers when I first went into practice 25 years ago. I wrote 7 papers in 4 years on complications. I presented 8 of my own vascular ischemic events before 2011. After 2011, I've not had any, knock on wood, because I made structural changes in my practice and in my techniques. I've been fortunate in me and in my clinic, and I've got 4 injectors in my clinic. We haven't had one. But I reported on multiple ones because we didn't even know what it was at the time. We were getting strange reactions, people were getting pain, and we didn't even know at the time about hyaluronidase. So we figured this out all along, how to treat these patients better and to get good results. But there's something I realized along the way. Who do you call when you have a complication? You can't really call your best friend. You can't really call your sibling because they don't really understand it. Call them and say, I got this problem, I don't know what to do, or if something really bad happens to you. If you get a complication, we talk about complications, well, you're going to get the how to treat it. But who do you call if you have a problem? I know of at least 3 of my good friends who are fantastic doctors, some of the best doctors in the world, the best injectors, the best trainers in the world, who have had horrible complications, even blindness. Could you imagine going to work the next day after you blinded someone, a young, healthy person? I don't know if I could do it. I think I would struggle. I don't know who I would call, who would help me through that. So my thought is that peers. Where are your peers? Who are the ones you call? And I will tell you, throughout my years, because I've written so many papers on complications early on, I would get so many calls from peers. Steve, what can you do? Can you help me get through this? And I would coach them through it. Truthfully, I don't do much of it anymore because I was getting sued, not because I was the one who did the malpractice, but because the patient would eventually sue the doctor, and then they named everyone. I had to be an expert witness. So I became an expert witness 2 times to describe what happened. In the U.S., we have a litigious society, so I don't take those cases as much as I did in the past. What everyone worries about is blindness, of course. And I don't think I need to give you the numbers. It's increasingly so. It's probably underreported throughout the world. I think it's much more than 1 in 5 million cases. I think it happens more than that. And it can happen from anywhere in the face, but clearly the nose and the glabellar area are the 2 most common areas in which it can occur. So you have to be very careful in those areas if you're going to treat those areas. And there's certain techniques you can use, and I refer you to papers I've written on how to manage those. There's nuances to how you can do it, so you don't you reduce your risk significantly. As Lisa said, I don't think you can ever completely reduce human error, but there are many things you can do, many things to reduce your risk of getting blindness. One of the things you can do, I believe, is cannulas. And I refer you to this paper that came out by Alam. It came out in 2021, looking at vascular occlusions on a survey of dermatologists. 30% of dermatologists have seen a vascular ischemic event. 1 in 6,000 chances if using a needle, 1 in 40,000 chances if using a cannula. It's a pretty big difference. 77% less likely chance of reporting it if you use a cannula versus a needle. 7% reduced rate. Also for people who are more experienced. Why, if you're more experienced? Well, you should know the anatomy better. But I think there's another thing that happens. As you get more experience with fillers, when you inject with your needle, you create a motion. You know how to roll the vessels along with your injections. You don't stab. That stabbing technique, every time I'm teaching a young resident, fellow, or injector, they're stabbing. That's when you get into a vessel, whether it's a cannula and a needle. But this paper really solidified something that I learned in 2011, that I went to cannulas. And I am 99% cannulas. I do use needles on occasion, rare occasions in certain parts of the face. And I do use needles very often when I do treatments for research trials. So I'm oftentimes using needles in the nasolabial folds and in the cheek and the lip for studies. And when I use the needle, I'm very careful. Keep the needle moving at all times. Small aliquots, injecting slowly, maybe aspirating if I'm in areas where I think there are large vessels. But Sebastian has showed us, Cotofono, that vascular anatomy is variable. The depth and the position of it is variable. So you may think you're great at it, but are you really that great that if you do 10,000, 30,000, 40,000, 50,000 injections over your career, you're always going to miss? Eventually you're going to hit one, regardless of where you think that vessel may be. Another, all cannulas aren't the same. A 22 gauge cannula takes 50% more effort or energy force to get into a vessel than a 25 gauge cannula. 25 gauge cannula is much less protective than a 22 gauge cannula. There are rare reports with 22 gauge cannulas getting into vessels. There are some, rare. 25 gauge, there's more. 27 gauge cannula is the same as the needle. There's no difference. So if you're going to use a cannula, just go to the 25, 22 gauge in my opinion. It's so much safer. Once you start doing this, you get used to it, and I think the results are better over time. It's got a longer learning curve, but I think it's safer. So that's one technique you can do to reduce your risk if you're looking for ways to reduce risk if you get into a problem. Hyaluronidase, which we talked about. At first, when we first started recommending hyaluronidase, we would just give a little bit. Great paper by Derek Shumate, looking at how much hyaluronidase you need. And for each 0.1 cc of 0.1 cc or 10 units of hyaluronidase, you're going to get about 0.1 milliliters of filler removed, especially Restylane more so than the Juvederm products. Restylane is a little bit easier to break down. Having said that, all the HAs get broken down with the hyaluronidase. High doses of hyaluronidase get to flood the area. So what I would tell you if I was giving you a recommendation is make sure you have 10 vials of hyaluronidase in your office. 10 vials of hyaluronidase in your office. That is the most important thing, is to have 10 vials of hyaluronidase in your office. Because you never know if you're going to have to use it. So we can significantly reduce the risk. And I think as Sasha just said, you're going to have, or Patricia said, you're going to have a complication. If you do enough of this, it's going to happen to you. Be ready for it. And make sure you're best prepared. In my office, we have a sign that goes up in every room within the cabinet. What to do if there's a complication, because your nurses will be surprised, or your PAs or your assistants, they get scared, they get flustered. Have everything ready to go, a crash cart, how to treat the patient if you think that you're going to be doing a risky area. And complications will happen, be ready, and when it does happen, have someone you can call. Have a colleague, a peer, a friend that you can call to help you through it. Thanks so much for listening.
You can just stay up there with your discussion. We're going to do a quick discussion in about 5 minutes to discuss if there are questions for you or about. I actually have a question for you.
Yeah, please.
You said that you had introduced items into your practice to reduce the incidence after your first couple, it's been a complication. Did that include a checklist like what you described on the interior of your cabinet?
So the checklist we have is for what to do, it's a protocol, what to do if we're going to have a complication. How do you manage it? And we have check the vision. We do that first, make sure that it's one side versus the other. But then we call the ophthalmologist. We have an ophthalmologist number up there. We have hyaluronidase. We have steroids, which I think Dr. we give that too. We have now we carry Viagra in the office, which is kind of funny today because a huge box of Viagra shows in the office. And one of my new assistants came and she goes, Dr. Diane, did you order this? There was 10 vials of Viagra in the office. So we have that in the office too. So that's on the checklist of what to do if we have a problem. Call the emergency room, make sure that make sure they don't have any stroke.
So do you ever run drills?
Pardon me?
Do you ever run drills in the office? Like, okay, like you're sitting down for lunch, and you're like, oh, there's a blindness. What are you going to do?
So we have not run drills.
I haven't done that. That's going to be about doing that.
It's a great idea.
Yeah?
It's a great idea.
Because it's going to, it's just going to reduce panic. It's going to reduce, like, fear. Not, I just think that people are naturally, they're afraid of, even though they have the checklist, even though they feel like they're prepared, they're scared that if something actually happens, they're going to panic. And now, if you're going to drill, there's really kind of more self-confidence. I don't know.
I think it's a great idea. The other thing I recommend is get an ophthalmologist that's on call for you who can manage a blindness case if it were to occur in your office. That's now for every clinical trial I do. I'm sure you guys recognize this also. We can't do clinical trials anymore unless we have a sub-I as an ophthalmologist who's on call for us. Fortunately, I've never had to use that call, but I do have someone.
I think we're going to move on to Dr. Ogilvy, but this reminds me of the board question we have in otolaryngology that says, if you cut the facial hair, what are you supposed to do first? And it's basically phone a friend.
Yes.
Okay, I think we have almost already covered all important aspects of how to deal with complications. One being, I think, mentioned by Tanya, is availability. And availability not only to make the therapeutic intervention, but I would like to point out that it's also important to make the proper diagnosis because it is not always what you think it is, and we are somehow always going the direction of the mainstream. And at the moment, everybody is aware. You heard Steve Diane saying that when he first described the vascular side effects of hyaluronic acid, nobody even knew what it was. Today, I think many people know. And then the next, like almost reflective reaction is hyaluronidase. My cases here show that it's not always in need of hyaluronidase either. So I call it take the call. The scenario is under eye swelling. We all know that we hate it, yeah? So the assistant says, patient calls, there is a swelling under the eye. I think you injected her 3 months ago. So what do? We have a tendency to shy away from that. And the best would be that the assistant is trained to talk with the patients through it on the phone, and we would love to not see this patient. I would like to show you why this is wrong. So 4 scenarios, no penetrations. That's the call. First, it's not a subacute or acute side effect. It is a long-term side effect. I had not injected her. She came in. Patient history. Painless swelling since 2 years under the eye. At some point, it became unattractive in her own eyes. I wonder why she endured for 2 years with it. Unilateral, localized with the treatment, bluish color. She had a lower blepharoplasty, and the surgeon had injected directly after an unknown substance, obviously hyaluronic acid, because it had a bluish color. I didn't need to take any further interventions or diagnostics in that case. Case 2, I injected her tear trough. She came back after 3 months, swelling, unilateral again, recurrent, but it always stayed on one side only. Red, warm, painful, and after vigorous interrogation, I would call it, she reported that she had recurrent epiphora, which is stripping of the tears from this eye, and also recurrent bacterial conjunctivitis in this eye. So we decided to refer her to a radiologist, and she had an MRI scan with contrast agent. Third case, patient with origin from Turkey, and she came with, I will tell you in a minute why this is important, acute painful swelling, unilateral above and lateral to the side of the treatment. I had injected her medial anterior and lateral cheeks with HA. It was red, warm. She has a history of repeated depilation her facial hair with what they call Turkish threads. I don't know if you have ever seen that. It's a technique which is very widely used in the Middle East, and I think also in Asia. The beauticians use 2 thin threads, and they are removing the hair with it in these beauty parlors. So no further diagnostic needed. And that is the 4th case. I injected her with calcium hydroxyapatite a day or 36 hours before she called. I had injected her cheeks. She called acute swollen swelling, bilateral, nearly below the side of the injected product. It was red. It had already initial blistering, and it developed this slight margin of hyperpigmentation around it. And this is where I love to be a dermatologist, because we are so trained to make snap diagnosis by just looking at the image in front of our eyes. Because I saw it and I asked her, did you cool the area that I had injected? And she said, yeah, all night. And I took the cold packs out of the freezer all the time. So she excessively had cooled this area for over 12 hours. No further diagnosis. So my diagnosis. The first is an HA lump with Tyndall effect. The second turned out by MRI scan to be an inflammatory reaction of her tear gland due to a stenosis of the tear duct. Third one had an acute phlegmonic infection due to the fretting. So she had introduced some bacteria into the site of injection. And the last one was chilblains, frostbites, due to the excessive cooling. And these four differential diagnoses led to four very differentiated therapies. First one is the one that I injected with HA, and then I re-injected her with hyaluronic acid later on. And then she gained trust in me because I fixed the problem, and later on I could also fix her spot eye, so I did not produce that. I wanted to point that out. the dactyl cystitis, as we call it, was a surgical indication. So she got a surgical intervention, and we have the experts on the panel here. I think four of them are experts on that. It's called Toti's surgery. So she had a recanalization of the tear duct and an antibiotic treatment in the meantime. Totally solved the problem. You see a little scar in the medial eye angle. Third one I treated with antibiotics only, and it dissolved. And from then on, she does laser epilation rather than Turkish threads. And the last one was just treated with a topical class 3 steroid, and that resolved within 2 days. So I second on what Sasha has just said about have steroids. There are topical steroids, oral steroids, and IV steroids. All shades of steroids help a lot. So conclusion is take the call and see the patient. Make yourself personally available. Don't delegate this crucial part of differential diagnosis to people that are not as trained as yourself. Do a diligent documentation of what you have done personally through clinical examination. It's more important than technical and laboratory screening methods. Have hyaluronics available is crucial, but it's not always the only solution that we have. I want to point out not every non-surgical intervention induced complication has a non-surgical solution. So you need surgeon friends. And I can only resonate that have your network in place. You need good friends because when things go down, you really need people that are in good intentions helping and supporting you and not people talking badly about you as a patient. And not every filler associated under the ice and isolate contact model as well. So with that said, I would like to take your questions and your comments.
I have a question for you. Dr. Ori, do you ever use injected steroids under the eye for either lymphedema or even if, with your hyaluronate in order to relieve edema?
I like to shy away from that. I know that Rosa Seckerstein, I think, is the expert on that, and she's published on it. I can only recommend. She shows amazing results. I have to say, I never really had to, which is probably not saying that I will never do that. I'm a little bit scary because of the lip atrophia that it might induce, specifically under the eye. But I mean, we don't trade safety for potential aesthetic outcomes. Yeah, that is also an important learning. At some point, the patient will have to live with the scar if it's necessary. Yeah, so I think that's when real bad things happen. It's time to change your aesthetic hat to the real doctor hat. This is also something that we have to keep in mind. At the end, you have to be the doctor. No harm first.
Patricia, I have a quick question for you. The first patient you showed, I think you said she had a blepharoplasty also.
Yeah.
So when you see a patient that has previous blepharoplasty, are you cautious about putting filler under their eyes and or neuromodulators at the same time, or separately?
Yeah, absolutely. I think, and I think all of you have seen that. The change of the local anatomy with the lower blood vessels is quite substantial, and you can probably much better explain what you actually do when you do a lower blood vessel. But it changes the anatomy, and the likelihood of a filler to end up not in the place where we intended it to sit. That's what I'm saying. I mean, I wish we always knew where we are when we are injecting in the cadaver lab. We frequently see you think you are on the bone, then you open up, you are far away from the bone. But in the lower eye area, we see it specifically frequently. And I have become, over the years, totally honest with the patients. I tell them when they come for tear drop injections, I say, I can do that. I've done that a lot. I've published on that. I think I could claim myself an expert on it, and because I am, I cannot promise you that this will give a good result. That is the most frequent area where unintended and also aesthetically just not intended side effects happen. Are you willing to sign up for that? And I'm conservative in the tear trough. I like to correct the tear trough indirectly first as much as we can because, and we see it all the time. One side is a good result, and the other side, for whatever reason, is not. Most of the time, it's just not meeting the aesthetic outcome expectations of the patients.
We just have a few more limits with you as well, but I would add that some people believe that with hyaluronidation can fix almost every problem. I'm a believer that if you compress the area over time, you may create a lymphatic outflow problem and it will never resolve. What do you think about that?
Absolutely, and specifically in the lower eye, and specifically with Tyndall, but also this recurrent swelling, we see that all the time. That is another important point to make, specifically when considering to fill or not to fill. Yeah, the question to fill or not to fill in the lower eyelid area is specifically crucial, and I tell the patients that because some side effects might never fully resolve.
I think
I'm sorry. Have you ever seen the swelling of
Orthopedic, you say it orthopedic.
by the way, this is Dr. Omogi's sister asking her questions on the podium.
Does anyone have experience with this topic on hyaluronidates, which surrounds us recently, which is claimed for this under eye swelling and puffiness after hyaluronidates?
No,
Yeah,
I've seen,
your experience.
I've seen it, and I have unopened boxes in my office.
And we use it comes from some cases, but it's not, it's not too much of a problem in hospital.
Yeah, I can't imagine that it would be anything but a better way.
There's one last point I want to make, if that's okay. The under eye swelling, have you ever seen it 4, 5, 6 years later after being treated? And the patient comes in for circles or something happens, and you're like, how do you manage that?
I mean, this case was one of those. It was a couple of years after she had reported to me that she was injected. It was not in my records, but she got an injection elsewhere, and she was credible. So I think it was really many years after. As I did in some cases resolve with hyaluronidase after all those years. What also the facial plastic surgeons can confirm that hyaluronic acid in the lower eye area lingers on forever. It's not a transient thing. It's not non-permanent. It sits there, it stays there, and it causes problems that are haunting you and the patient forever.
So what the comment is that, so my practice, I've been doing this for 20 years. My practice, pretty much the only time I see, this kind of edema and this kind of swelling is several years afterwards. And I don't see it right away. I see it, the results are great right away. Maybe 4 years later, 5 years later, 6 years later, they come back with it, and I think it's part of the reason that it's breaking down a little bit, exposing more surface area to fluid of the living tissues, absorbing fluid and living fluids. So, yeah, in all those cases, for me, in all those cases, I want to
And the smaller fragments become slightly more pro-inflammatory as well. Yeah, so it's a vicious circle. It's a downward spiral. So it's yeah, and I mean by then someone else might have posted the great before and afters and attracted hundreds of more new patients because you simply don't think of it in the long-term perspective. So only by experience you become a little bit more conservative.
You know, one short comment, if you open the both see it's going under the arm.
Mm.
And that's important. And also how the patient sits on each side. So if they have a swelling left, I always tell them try to sit their right. And some both have started to still one, but they sit cover with the That was
In sometimes when you have previous paroplasty, especially in the upper eyelids, I found that it's also useful to blend the hyaluronate with collagenase, or maybe to use before collagenase and then the hyaluronate. And sometimes you can do a kind of substitution with the cannula, and then the edema results better.
I think that's a crucial point because we think, I mean, we have been a little bit narrowed by the industry that is producing hyaluronic acid to reduce our notion of the extracellular matrix to hyaluronic acid only. There is a lot of other extracellular matrix components around that start changing when we are injecting, one being the collagen. So just by the sheer mechanistic stress to the fibroblasts, we are changing their behavior and they start producing different types of collagen and different amounts of collagen. So the structure changes, and using collagenase is a very smart addition. It causes significant erosion. So, yeah. Thank you, Julieta.
Thank you for your kind introduction. We are not going to have so much time, so let's start with my cases. The first case is a lady on who I performed rhinomodulation 3 times, as you can see, with an improvement which was more noticeable each time. But my first question here is everything what it seems? The second case, this lady with this alopecia plaque, and my question here is, would I have treated her if I had known she would develop this kind of alopecia plaque in her scalp? So, as I told you, I am Dr. Espada from Buenos Aires, and these are my disclosures. Please, if you have any doubt or any question that we can cover during the session, don't hesitate to scan this barcode. So let's come back to the first lady. These pictures are immediately post her third procedure. As you can see, without blanching, libido, papules, pustules, pain, and excellent results. In fact, the patient was over the moon. This was the view from below. But 5 days after the procedure, she evolved with some pain and this erythema inside the nose with some vesicles. So we asked her to come to my office, and this is how she was when she came to my office with this kind of strawberry pattern inside the nose. So I must confess that I had to work blind because I tried to use my ultrasound, but it was impossible to reach the septum inside the nose. So I had to work blind. I just was guided by her pain and the color of the mucosa. So I decided to start with the hyaluronidase protocol. And in this case, I used 500 units intense massage. I repeat 500 units, always guided by her pain and the color. And that day, I did 4 cycles of hyaluronidase. Of course, I also gave her aspirins, antibiotics, and this is how she was the same day after the 4 cycles.
And 48 hours after the procedure, she was still with some pain, erythema, crash. So, you know that I thought that when you use hyaluronidase, this substance can break into smaller particles, and these particles could impact in a distal part of the vessel. So I added 500 units more. And this is how she was the same night after the additional units. As you can see, the better color of the mucosa, a more homogeneous color, and this time the lesions seems to be blisters more than vesicles. So I assume that these lesions were due to liquid extravasation more than ischemia. And this is important to distinguish. And this is how she was 14 days after these 500 additional units with a total recovery of the signs. You know that I didn't have a rhinoscope in my office, and after this case, I got one. What I found interesting about this case is the fact that maybe when I did the first inch, I did it at the spine and bone, and maybe some, let's say, particles impacted in one of the anastomosis between the external carotid artery system and the internal carotid artery system. Specifically, in the anastomos between the superior labial artery or columnar artery and anterior ethmoidal artery. So it was quite difficult to be aware of early signs of nasal necrosis, as this was inside the nose. And this is the second patient, a lady on who I performed temporal fillers and temporal lifting technique the same day, the DIAP technique. As you can see, and I also did her lips, but as you can see, immediately after the procedure, with good results on her temples and also her contouring. But 1 month after the procedure, her daughter wrote to us explaining to us that her mother had started with some pain the same night after the procedure, and the day after she evolved with some lesions in her forehead, some papules, some pustules. So she went to a nearby pharmacy and she self-medicated with oral cephalexin, a cream with silver sulfadiazine, vitamin A, and lidocaine, which in Argentina is called Platsur, and nothing else. All of this was requested by the pharmacy. And 1 week later, she evolved with the alopecia plaques, and 3 weeks later, her daughter decided to write to us. Do you follow me? Okay. This was the patient that I showed you, and this is how she was when she went to my office. Unfortunately, I wasn't there because I was in a medical congress in Germany, so she was seen by a doctor from my team, and the patient, as you can see, has this erythema in her forehead, this alopecia plaques with also erythema, crust, broken hair. So she decided to start with the high-dose hyaluronate protocol, and she did 2 cycles of 450 units. Of course, she also gave her 2 baby aspirins, the per day, the one per day, and antibiotics. 4 days after I was back in my office, and this is how she was, of course, still with the lesions. And this time, I decided to add 500 more units, but this time, I decided to blend the hyaluronidase with minoxidil to the alopecia plaques, and I also suggested at home bimatoprost, topical, and to continue with the baby aspirins and the antibiotics. And this is how she was 6 months later with a total recovery of her sight. So the question here is, was this due to embolism or compression? What do you think?
Compression.
Compression. Okay. I have my own conclusions, but I would like to have yours in the panel and maybe in the audience, because please take into consideration that I did both procedures the same day. And please don't forget that we can also have pins and coils along the superficial temporal artery trajectory to make things harder. As conclusions, not everything is what it seems. Would I have treated them anyway? Of course, I would have treated them anyway, because as we told previously, when you have these kind of complications, you don't just learn from the complications. You become a better person. Because you know that sometimes as physicians, we have a kind of omnipotence, and these cases bring us down to earth. So let's have a debate. Thank you so much.
I have a very practical question. Do you pay for these medications for complications that you have in use, or is the patient paying for it?
No, I pay.
Opinion?
That's always risky because once you start paying, then you can, well, the U.S. is different than every country, but in the U.S.
Could you explain, because we are not in the US, I think there are many people here in the audience that are not from the US. Why is it difficult if you pay out of your pocket and don't let the patient pay?
because then one is you're admitting some sort of guilt, but that's not, you're paying you're always trying to pay damages. Damages are the effects from the treatment that you did. So then, if you get sued, you've already gone down the route of paying damages for your intervention.
What about something like hyaluronidase? Did you use that for free, or do you charge for that in a
Hyaluronidase include.
Yeah.
Okay.
Yeah. Okay, just to be clear on that.
Yes, I also do.
Can I ask you a question? When you injected that nose, I've never seen that before in the septum. Where was the injection to get where you think that caused that?
The first injection
Is
was
that the
defined very deep on bone. And I think that maybe when I take out the syringe, maybe I could embolize a vessel there.
I've never seen that.
It's very weird. It was my first time with this.
Can I blatantly advertise our session later this afternoon, because the Philippine is going to inject in me live?
Hopefully this is not setting up next year's complication session. I'll be up there and saying, well, last year.
With very careful mapping the vasculature of the face before it's in.
Last year we were doing a session and Ali was injecting. He got into the artery, got a huge flashback up here on stage. And that was like the first time I saw him on stage like that. It was the greatest example of what not to do, or what to do, I guess.
So now you should examine it inside the nose after the control. You know that when the patient did a non-surgical nose job or rhinomodulation in my office, we ask them to send us pictures during a week just to see and to control the evolution. But now, after this case, we are asking them to send us a picture from below just to see the fossa. Yes,
Because I always tell my patients the next day they have pain, and it's more than a normal breathing.
yes, she had
The
pain.
pain is a good
So that's a really good point, and I think it's more important to also have your staff be educated on this, because the patient will call and say, "Oh, I'm bruising, I'm having pain." The staff's like, "Oh, it's nothing, no big deal." They've got to tell you, because that's they miss it.
Yeah, but it's important also to differentiate when they have pain. Do you have pain when you start and localize, and do you have permanent pain? Because it's different. But now, after this case, all of my staff is also trained with this weird data again and again and again and again, because I think that we largely underestimate the side effects of temple injections today, because we are just about to start to roll out the concept of injecting temples at all. I realized that when, I think, Steve, you showed the sketch of Katie Dallasmy's paper with the dots on the face of the areas where cases of blindness were reported. It is a very good paper to read, but it was written before the rollout of temple injections. I would assume if we would revise that map today, there are more severe complications after temple injections. And people simply do not know that you can have distant effects when you have had a temple injection, such as hair loss on the scalp. And nor do the patients, by the way. I reckon a lot of patients encounter that and don't even come back because they don't connect the dots.
Perhaps the comment also to this, the hair loss is quite delayed, but what we see is that they come and look like shingles or herpes. So if patients newly injected around the place of slightly to the body and they have the next day still pain appear and looks like shingles, it could be also a field illusion. We see that more often now. Okay, we finished. I just want to thank all of the panelists for such honest among experts. I think people think that my because bad things don't happen to experts, but it happens to everybody. It's just a numbers game.
Okay, perfect. Thank you. Yes, bad things do. Hopefully not as bad as this, but still bad. Like don't, hopefully nobody's nose is gonna fall off in your practice. Anyway, so this patient came to see me. She wanted a non-surgical rhinoplasty, and she was really, really nice. She's a 36-year-old flap nurse. Now, what a flap nurse is, Steve will know. Well, some of the people in the panel will know what this is. But you guys may not. Flap nurse is a nurse that works with facial plastic surgeons, to help them in surgery and also afterwards to monitor the flap, whether it's a free flap or it's a pedicle flap, and make sure that it's nice and healthy and survives. So, day in and day out, she, in her career, was watching for ischemia and necrosis. Now, this may be a premonition of what's to come in my presentation, or may not. But anyways, she didn't tell me that she was a flap nurse. She just told me she was a nurse. So throughout this time, I was just thinking, didn't notice. This will come into play maybe later on in the presentation. She also had several rhinoplasties. She had 2 rhinoplasties in the past, and she just wanted a little bit of contour adjustment to the nose. She wanted to do derotation and filled in. She wanted to fill in indented contours and retracted halar, and she really wanted very minor corrections. So what I did was 0.35 cc's of Voluma with a 0.3 cc BD syringe, 31 gauge fixed needle. This is how I inject noses for the past probably for the past 8 years. I've been using backloading these syringes. I think it really makes sense from a variety of standpoints. From first of all, from in terms of patient comfort, the needles are so tiny that they really are barely feel aerated, and they don't. It's not too bad to fit. So from that standpoint, I think it's really nice. From the standpoint of precision and some results, I think it really adds to the ability, because you're injecting 0.01, 0.02 cc's. You really can be very, very precise in the results. Really, I think it makes a difference in the results. So that way, and third is, I think, more safe because you're injecting tiny amounts. And I think that, again, and this is something that I'll repeat in this presentation, I think the most important thing about safety, whenever we do any kind of injection anywhere in the face, the one rule that if you want to know, the one thing it comes down to is you don't want to inject a large amount of filler into one place under pressure, and that's it. If you can just not do that, you'll be considered, you'll be safe. And that is what determines safety. So I think because we're in and out of vessels all the time, we get cruising, we have to not kid ourselves. It's not, it's not the 100% avoidance of getting into a vessel. The point is not to get into a vessel and slam a whole bunch of stuff in there. And so if you inject in very tiny amounts, and I always move when I inject, that goes a long way to keeping me safe. So I did tip, the tip lobule sidewall, there was some good activity from her, just tiny amounts. And this is what she looked like afterwards. And so, great result. So, all done, send her home, everything's fine. Thank you very much. Okay. No, that's not the end, because let's take a look at her one more time. Tip of her nose is a little bit gray. The area superior to her lip looks a little bit blanched. And so I was a little bit worried about her, but not, she's had a couple of rhinoplastics. I see that. I see kind of with little bits of ischemia fairly commonly around the tip area. And so what we did, I did massage, warm compresses. I think that, there's always going to be a little bit of vasospasm after in patients who have had rhinoplastics in the past. I reassessed her after that, after 30 minutes. She looked good, nice and pink, and I sent her home. Great. However, 2 days later, she developed pustules and pain on the night of post-procedure day number 1, worsened by night. She had to take Percocet to go to sleep. Advil wasn't cutting it. And she came in and so she called, so we came in, and so I was concerned about that, and she came in, she looked like this, which is not what I want to see, right? So, this is the other angles. This is very clear. There's not much doubt about what's going on here, right? So, her husband is an ER doc. It's very clear as to what this is to us. It's not very clear as to what this is to people that are not in our industry. Because we talk about this all the time, but ER docs don't. And so to her husband, this was a skin infection, so he wanted to prescribe Doxy, but she wanted to come and see first, which is good. This is clearly necrotic skin changes, and my main goal looking at that was to limit the depth of injury. So I did Vitrace 2.2 cc's. I put her on Midroll dose pack right away, warm compresses, nitrodid, and aspirin. After all that, she looked much worse. And my unhappiness is now profound. I send her for hyperbaric oxygen that day. So what's going on? Is this symbolic or is this compressed? Is this lateral nasal artery? Maybe for variant course, but you know what? I doubt it. I don't think this is symbolic. I think this is probably compression. Tip of the nose, that's what I see as I think more compressive events because it's a really tight space with tenuous blood supply. So especially given the previous history of rhino, and I think she's probably having some vasospasm. So what are my goals? Reestablish blood flow, decompress those vessels, resolve vasospasm, prevent inflammatory compartment effect. I think that's really, really important. And that's where the steroids come in. I don't want I don't want damage, inflammation in a tight space, making all the inflammatory edema coming in there, making that space even tighter and compressing even more, and this kind of compartment effect. I want to cut that off as soon as possible, hence the steroids. I want to oxygenate tissues, hence the hyperbaric oxygen, and I want to limit depth of injury, hence a very fast onset of treatment. I want to treat her right away. So after hyperbaric oxygen, and she never wavered from having a really great attitude about this. I'm very, very fortunate that and this is going to happen to somebody who was really had a really good attitude about this and trusted me, and I'm very, very fortunate that that's who she was. I've had this kind of thing happen twice before this, but last time was over 10 years ago. So it's been a very, very long time since I've seen this kind of thing. So now this is still post-procedure day number 2. I put her on when she came back from hyperbaric. She came back to my clinic. I put her on nitrous gas for 45 minutes. I think that works because nitrous oxide is a vasodilator. Nitrophase for 30 minutes. Because she's on the gas, she could tolerate the nitrophase. This picture, by the way, may have been taken when she was still on the gas. So that's why she's smiling, perhaps. So, anyways, that was actually quite helpful. So she sent her home on Medrol, aspirin, warm compresses, doxycycline, and Viagra, and no objection. Next morning, she looked like this. Not good. So I'm quite worried about an indented scar happening after the scar falls off. And again, bitrace, nitrous gas for an hour, nitropaste, hyperbaric, brought her back after hyperbaric. So morning session, afternoon session, bitrace, nitrous gas, nitropaste. This is very aggressive treatment. I was very, very worried about her. And because the previous cases, over 10 years ago, I didn't know what to do, and I didn't treat them this aggressively. And they did develop a little bit of indentation in this area, and it was really, really didn't want this to happen again. So after all that, she looks like this. But there's a glimmer of hope because the other side looks considerably better, and she had much less pain. So she was sent home aspirin, Viagra, Doxy, Medrol, and warm compresses. And the next day, so this is post-procedure day 3, this is post-procedure day 4, and another hyperbaric, so hyperbaric oxygen every day. Crest is off, there's no indentation, the erythema is improved. I am feeling much, much better about this. I know you guys really, the main thing is my emotional state about all this kind of thing, but that's very important to you guys, so I'm telling you this blow by blow. Anyway, so she's improved, and I'm very, very nice to hear that. Day number 6, things are looking even better. The 4th time she had hyperbaric. So then on day number 8, post-procedure, she's had 4 hyperbaric oxygen treatments. I think that's, that was enough for her. She was considerably better. She looks great. I'm a hero. Everything's wonderful. We're done, right? So we're not done, and I wanted just to make one final point. It's the point about this. It's a little bit unrelated, but I think very much, but it is kind of related because this is day number 8. This is day number 14. And you notice that the difference here is that this looks good because it's bad photography, and this looks not perfect because this is good photography. You can actually see there's still some residual erythema around the tip. We treated her with vascular laser twice, and I think we can use a little bit more vascular laser. So she clearly had a superficial injury that's still healing. And so but she'll be fine. And over a little bit of time, she'll be fine. This is the other angles. She looks great. So this is all the things that I did. I think in the order of importance. I think Medrol dose packs, hyperbaric, bitrace, aspirin, warm compress, nitropaste, gas, doxycycline, Viagra. I think clearly, of course, the most effective treatment that we did was the Viagra, and we're just kind of now every Viagra, everybody. No, I think the most important thing I think was the steroids and the hyperbaric and the bitrace. So fast, aggressive treatment works. And I'll open up the discussion. I just wanted to invite people to our high risk cadaver lab and live injection session in Los Angeles on May 20th. And you can sign up at the expertsymposium.com. And this is our social media, so you can take any questions. Thanks.
That was great. So I want to ask you a question. Can you put in context with me the article you wrote? You have one of the largest series ever published on injection of I think it was over 2,000 patients or so.
Yes, 1,000.
2,500. But this patient had a rhinoplasty in the past. What are your thoughts on injecting someone who's had a rhinoplasty in the past? What are your thoughts on teaching that to people who are just getting started?
Right. I think that's a great question. And I think that's so I'm writing a chapter now about that, and it's something that I really stress every time I speak about this, every time I write about this, is that in the paper it's clear that having a previous rhinoplasty increased your odds of adverse events by at least 50%. I think that's even a underestimation of how much. I think it multiplies your risk of a problem. I think that only expert injectors should be doing non-surgical rhinoplasty in general. I think that only expert non-surgical rhinoplasty injectors should even consider doing the procedure on patients who have had previous gynoplasty. Your blood supply is less, is altered. You've got scarring underneath the skin. Your vessels are fixated, so you've got more risk of a compressive event. You've got more risk of an embolic event. Your results are unpredictable because you don't know how much scarring there is, and you don't know how much the skin is going to rise. So I think that there's a lot of trouble in yeah, post-rhinoplasty these cases. So you got to be really careful.
Just got a quick question that's come up before in the broadcast. Is there a time limit you have for doing injections in post-rhinoplasty patients, or do you want them to be at least a year out, at least X amount out from their surgery before you think they're good candidates, even if there is that evolving scar, evolving compartment?
Yeah, I mean, classically, we give people a year for those for the results to evolve and for people to see it. So I think that's right. I think that's reasonable. You know, and I think that again, I'm super careful with these cases. So I'm always doing little bits at a time and I always stage these procedures in general. I always have people come back for a touch-up in 3 months. So I never have. I try to not have a pressure on me to hit a home run with it every time. I always bring it back.
Could you tell us what the hypothetics I believe absolutely in this, but it seems that the dermis to get into the family is very expensive.
Yeah, it was. Yeah, I mean, there's in LA. It seems like, and I don't know. You guys can tell me about this, but in LA, it seems like a lot of the Beverly Hills the plastic surgeons are now doing hyperbaric oxygen routinely after their facelift procedure. They're finding that it just decreases. Right? Are you doing that?
No, but I think a lot of people do have hyperbaric just because for the sake of time. We'll come back to that question, I think, about that dollar. All right. So I'm going to be sharing a complication that's not my own, but I sit there whenever I think about this individual. All I can think about is there are so many ways this could have happened to me. We're going to hit back on a lot of the concepts that we've heard from other speakers. The idea of the Swiss cheese theory, the idea of making appropriate diagnosis, being available, having your supplies in place, having that crash kit available, so that we can keep our patients out of these situations. So, what I have here is out of a 56-year-old woman, they're getting her first injection. She actually was from the town that Dr. Greenbaum and I are in, which is a large metropolitan area with well over 4 million people. She happened to go to visit her daughter in a small rural farming community where her daughter, for her mother's birthday, had gotten her injections for her first time to see if she could make her feel more rejuvenated. So she was injected with about 2 mLs of hyaluronic acid. We believe in Hungarian that might be usually called 5 report. We don't know exactly what product. And she was first immediate pain and discoloration. She was reassured by the injector that her pressure was, and it was treated with arnica and contrast. The next day, she ends up with worsening symptoms. Contacts the injector, who is very responsive, sees her immediately in the morning, looks at the area, there's discoloration, there's redness, there's swelling, all these things that kind of make us very worried. But she did reassure her and treated her with more arnica. By day 3, everything's continuing to get worse. She is in a rural area. There's not that many options or places to go. She was treated at a medical spa, and so she was seen again by the injector. And then, due to the fact that she did have these ongoing evolving symptoms, sent to the doctor that was the supervising physician at a different clinic. And this meant that we were now about 3 hours out from the injection. The doctor at that clinic treated her with his entire supply of Hylenex, which was 1 vial, so 150 units, and unfortunately she continued to work there. Since that had depleted everything that this individual had to offer, sent her to the local ER. Unfortunately, the ER doesn't have any expertise because they may have Hylenex, and so there was very significant reticence in treating her anymore. Ultimately, she was treated with an additional 450 units of Hylenex, but at
her entire side of her face, up to her nose, inside her mouth, and up her forehead. So by day 4, this is still getting worse. She's still not improving despite these interventions. She's still in a small space, and by the way, it's Christmas Eve. So you now have an injector that didn't have Hylenex, unfortunately, after the original site of treatment. The supervising physician did not have a large supply. The covering system that was the ER didn't have any expertise. And now it's also a holiday, and there's nobody to do it. By the way, there's also a snowstorm. So,
But what is it war?
so she'd like to come back to her hometown that's very large and has many centers of excellence, and there is absolutely no planes going out of the entire state. The entire middle of America is shut down by a snowstorm. So she's seen back by a local plastic surgeon that did come in on Christmas Eve. Someone managed to get him on a cell phone. He came in, he used his entire supply of Hylenex, injected the area, it was 300 units, and started trying hyperbaric oxygen therapy. They could find someone that had some availability. And then she sat there and she went to hyperbaric every morning and sat on the tarmac of an airport in a chartered plane for the next 3 days, waiting until the weather cleared enough that she could fly back to her home city. And just repeated that. And she just waited until the snow finally cleared enough that she could fly. So she ultimately does arrive in our ER. Unfortunately, it's now the week that's in between Christmas and New Year's, and all of our aesthetics providers are away seeing family. So we were called by the ER and they explained what was going on. Unfortunately, we're all gone. They do have Hylenex. They are comfortable injecting. We do have other microvascular surgeons and a plastic surgeon that's a specialist in hand therapy that's available, but otherwise she doesn't have a true cosmetic team immediately available. So she was treated with more Hylenex, but they decided instead to focus on getting her into hyperbarics. She was also seen by infectious disease because there was a significant concern that now you're a week out and it's maybe super infected. And by the way, it went all the way through her cheek. So this was the intraoral exam. So there's concern about this fistulizing through the cheek at this point. So the acute management for her was antibiotics and antivirals prescribed by the infectious disease doctors. She did get additional hyaluronidase. She got significant local recall. We live in the middle of the hottest desert that is kind of in the USA. So everything is about occlusive dressings because everything tries to dry out and die. But she also does venoforceps to try to get rid of some of that heavy custom she has in hyperbaric oxygen therapy. This is something that we're really lucky. We don't have hyperbarics at our facility, but the cosmetics team had previously found someone in the community that we knew if we called them, that they would see our patients on any day, 7 days a week. They run their hyperbarics from 8 a.m. until 8 p.m. every single day, and that we could get patients in. So there's a European consensus statement that came out in about 2017, 2018 on hyperbarics for compromised skin, and the recommendation was treatment about 209 to 250 kilopascals, minimum duration of 60 minutes, preferred duration 90 to 120 minutes. And so we set her up on that protocol. First day, twice a day, and after that, 1 to 2 times per day. And so this is what she looked like 1 week further into treatment when the rest of the aesthetics team finally returned from having visited our families. The intraoral component is not insignificant. There's actually a pretty significant fissure. She's down to being just barely not communicating out to her cheeks. Long-term management then happens for this individual because this wasn't kind of caught early, wasn't able to be reversed in this timely fashion. So she actually received pulse light therapy 7 times. She received fractal 4 times, fractional CO2 laser also over 4 times, and then intralesional steroid into the thickest parts of her scar. And basically, she was seen by myself, and we had an amazing cosmetic dermatologist that we shared this case with, and we were seeing her every month, and every month she was getting treatment. And she did well. This is something that was pre-rehab, so this is
months post-occlusion event. You can still see the irregularity down that nasolabial fold. She does still have irregularity in her glabella. It's something that she really notices, of course, even though it wasn't better. She's very disturbed by it. And she's very frustrated by one of the areas that, after mouth heals, that was the most significantly affected was that nose. She can't breathe. And she knows that on that front view, you'll notice that her right side, that air is really elevated. It's almost hidden. It's a little bit smaller. And by the way, the daughter that was kind enough to gift her with the filler got engaged on Christmas Eve, and she was in the ER, and her wedding is in 6 months, and she'd like to look better for that wedding. So this is one of those times where we were talking about the comment was made that not all non-surgical filler complications are fixed by non-surgery. Where she did actually end up with a small nasal procedure, all endonasal. This is someone with a compromised vasculature that is a surgeon. I'm not willing to do a big open procedure on. I just want to make her a little bit better. I'm never going to make her perfect. She's really aware of that. She's really open to that. But she does get a septoplasty. She gets grafting into that right side, AR-based grafting, batten grafting, and scar revision. And it's not perfect, but it's better. And she's happy with her. So now 3 months post-operatively from her nasal surgery, we've got better symmetry. She still has scarring. It is still noticeable. It is still imperfect, but we're kind of starting to hear from her that I'm comfortable going to my daughter's wedding, which is really helpful. So when I think about this case, it is something I really took away from it was the Swiss cheese. And it wasn't the Swiss cheese just where she originally got injected. I also felt very much like as an institution, we felt her way that we had all of the patients traveled all the way from this different state back home to get care at our facility, and all of our aesthetic providers were out of town. And as Diane had commented on, we're somewhat limited in how much direction we can provide long distance, having not seen the patient. We're not there to assess her. We're not there to actually do the treatment. So we can talk to our colleagues, but we can't make direct recommendations to her family. Ultimately, this was something where when you have these big complications, not only is it that relationship, just like Dr. Rickman was saying, in the short term, like this is a long-term follow-up. You don't get to necessarily take care of them, resolve it, and form that relationship. She's now 15 months out from her occlusion event and is still seeing her. And she's doing well, but it's that support through and through, I think, that is something. So that's the end of the case and any questions. Can we have maybe back to the question of hyperbaric, who claims how to do that and talk about the risk and a little bit more about that. This patient, we had the patient pay. Since we don't have hyperbarics at our institution, it's not something that we're able to directly provide.
Yeah, in my case, I paid for her hyperbaric, and
One thing
I know.
He's not in jail yet.
Yeah. You can talk to hyperbaric
also pay for it. Oh yeah, for sure. No, it was done through the hyperbaric, and usually I submit to the hyperbaric under the office. So usually I send the benefit. It's never an issue. Yeah, so but his was being repaired, which was really.
From our international when is the situation of the hyperbaric?
Something like that's so easy to find places with perform hyperbaric oxygen. But some public hospitals, I had a doctor in my team, and he performed the hyperbaric oxygen in her hospital. So I think they have in Germany, the situation is quite difficult because we have only hyperbaric chambers for the private medicine. And those are the big ones. We have to go 2 hours in there to sign the last products. We also could have side effects for that. I think the hyperbaric oxygen that we do talking about are much more easy. And this is not popular in Germany. No, it's difficult. During the pandemic, I they had the idea to use all the airplanes that were grounded and refurbish them into hyperbaric chambers because airplanes are, the cabin of the airplane is equipped for high pressure. So he started that as a startup company, but then after the pandemic, I think they needed the airplanes again.
When we were doing all this complication stuff and trying to fix out how we get the points together, and so I was calling them, and they really looked at me if I'm crazy. They said, we've got really problems now with the pandemic and the COVID. They're completely correct. And he told me that those softer ones we wanted to use, but they're not really effective. He said
Right.
you have to
So
breathe
this,
into
so
this
this is the thing.
10 times. Because we had one blind street in Germany, which I was kind of treating with and tried to help her. And she said the only thing that really helped her for the blind was the hyperbaric chamber,
Yeah.
the intensive one.
It needs to be a hard chamber. It needs to be, because there's soft ones. There's basically there's hyperbarics that are kind of like, kind of, yeah, like spa treatment. So there's like spa treatment hyperbaric where you go down to, there's a very low depth, like it's not a lot of pressurization. But I think I forget how they measure it. ATA or something like that. So it's 3.0. 2.0 to 3.0, I think that's where the medical hyperbaric treatment is, and that's what, and you had to like specify when you started calling around. Can you take them down to a depth that is medically appropriate? But I think that it'd be interesting to see how this year after year with this panel, because I think my prediction is that more and more countries, that's not going to be an issue in Germany very soon, and I think in Argentina soon after that, because it's just a few years ago we didn't have that many hyperbaric oxygen either, but now it's very much.
The US in this case always in the beginning. They're always the next first. Yeah, I think that's what
The more this is going to be published as a way of solving problems, it is going to be probably also legally mandatory to make that available to patients.
Yeah,
The
because
sequence of events normally is like that.
because you saw the pictures in my case, it was very clear before hyperbaric and after hyperbaric. I mean, I saw an immediate change, and it was very dramatic. So I think it's pretty cool.
somebody in the audience who has some experience from different countries. How did you do that?
Well, I would actually search for an opportunity to send patients hyperbaric chambers, and I found out in Germany it's really great to contact the military.
Contact what?
The military hospitals, they have,
But they're full now. They don't take any after. It's a matter of availability, actually. And I have another question for the panelists, because hearing this session, don't you inject before you're planning to travel or to go to conferences, or the other way around? Would you recommend patients not to be injected before the huge international conferences you take your paper because no one will be available for them if something goes wrong?
you have to have a good trained team at home.
There are people that inject in hotel rooms here, so indeed.
I think that's the other thing.
Okay, so I'm from São Paulo, Brazil, and over there it's very popular. It's not popular, but we have a lot of hyperbaric oxygen cabins because it is a new market. So I know a plastic vascular surgeon, and he treats a lot of wounds, and he started doing for his own work. So now he has a lot of plastic surgeons, all kinds of surgeons that use his service, and he's multiplying his hyperbaric oxygen cabins, and he's making money with it.
Yeah. Many opportunities.
They have to go 10 times the time.
The one that has the regular discussion without session.
Yeah.
Just please, Joe, pass information for this page.
you want to ask for when we're trying vascular problem, which is pretty well known to us who work with it because we have problems before, especially with diabetes. Pretty sure that all doctors have seen the side effects of that result from diabetes. It's 1.5 to 2 atmosphere. So if you ever want to ask for a specific and send a patient right away into someone who's got a high pressure, high cardiac which in Spain they're getting pretty famous, and we have chambers that can just take personalized treatment because every single patient has got his own oxygen tank, reducing special kits in which we can perform not only pressurize the chamber that gives you exact amount of air in terms of volume and pressure, but you want to ask for 1.5 atmosphere and high pressure. Just that.
Thank you. I think everybody of us should ask in the cities were around this to come have the transition. That would make sense. I should go and visit and say hello.
Make friends.